Nation Leadership Forum, proudly brought to you by these sponsors.
Alkhair popote unapopokea taarifa hizi na vile vile mjadala na kikao au warsha hii ambayo katika chuo kikuu cha Nairobi, na bila shaka matangazo hayo unayapata mubashara kutoka eneo hili. Ni kongamano au warsha ambayo imeandaliwa na Nation Media Group, warsha ya uongozi na mauongozi, na vile vile maongozi ambayo tutakuwa tunagusia na kuchambua athari zake kwa Wakenya kwa ujumla, kutafuta kuona kwamba moja na moja tutapata 2 au tutapata 11. Iwapo tutapata 2, iwapo tutapata 11, tutaangalia ni kwa nini au ni kipi kilichopelekea sisi kupata 11 badala ya 2. Yote ninayozungumzia ni kuhusiana na athari, ima kwa upande mzuri au upande mwingineo. Kumbuka kwamba Kiswahili kimetambuliwa kama lugha rasmi, na ni lugha ambayo kama tulivyosikia taarifa za NTV ni kwamba hao madaktari wa Cuba watafunzwa Kiswahili. Sasa mafunzo ya Kiswahili, kinachoofisha hasa kwangu ni kwamba sijui muda wa mafunzo ya Kiswahili yatachukua urefu gani, kwa sababu unaweza kumtibu mgonjwa kabla ya muda wa mafunzo uishe. Manake mtu kama lugha si yake inakuwa mtihani sihaba. Lakini yote hayo 9-10 ni kwamba mambo yamefanyika, na kilichofanyika kimefanyika, tunakumbatia na tunaenda nacho. Waswahili wanasema ukipewa kilema bila shaka unapewa na mwendo. Washakuja, wamepokewa, wengine wameanza kuchapa kazi rasmi katika maeneo tofauti ya kaunti 47 humo nchini. Kumbuka kwamba kuja au ujio wa madaktari wa Cuba ni swala ambalo limeibua hisia tofauti. Wengine wameliona ni kwamba ni raha, wengine wameliona ni karaha. Kila mtu na sababu zake. Lakini yote ya kuyachanganua kwa mapana marefu sitaki kuendelea sana, ila mwenzangu atakuwa anachukua usukani kutoka hapa. Laban, sina la ziada.
Asante sana mwenzangu Harith. Tafadhali tupigeni makofi. Naomba nibadilishe katika lugha ya Kiingereza sasa. To our viewers tuned in to our platforms in Kenya and around the world, welcome. This is the Nation Leadership Forum, coming to you live from the University of Nairobi. Now, this is the region's authoritative forum where we discuss critical matters that are concerning you and find solutions to them. Now, tonight, it's all about healthcare, a sector that has come closer on the radar of government stakeholders, as it's one of the big 4 priority plans. Now, in fact, even so, we looked at towards there's a myriad of issues that face this sector, but tonight we focus on these critical aspects. Yes, Harith mentioned about the Cuban doctors, but more than that, access to healthcare, number 1, financing of healthcare services, human resources to health, and a lot more that concern these sectors on affordability, technology of health, telemedicine, and training. Of course, to drive this agenda, I have a diverse audience right here from University of Nairobi, including doctors, students, the Mwananchi's Voice, stakeholders from the private sector, and of course government. Now, give yourselves a round of applause for making it here. Also, I have a great selection of panelists representing all angles of discussion from top-down, bottom-up approach. I will introduce them shortly, but before we do, let's hear from our host tonight. That's Professor Peter Mbesi to give his welcome remarks.
Distinguished governors here tonight with us, the principal secretaries and members of parliament, members of the diplomatic corps, many CEOs that I see are present, and the staff of the Nation Media, distinguished invited guests, faculty staff and students and the general public. Good evening. Good evening again. I am always very pleased and honored to welcome you to this fora, the Nation Leadership Forum here at the University of Nairobi. I'm very sure that you will enjoy today's deliberations and leave here more informed and more focused on our intentions for achieving quality and affordable health services for all of us. The government of Kenya has prioritized universal health coverage in its Big Four agenda. This is an opportunity that we cannot afford to squander. We must plan together, reason together, and come up with solutions that will make us one proud, healthy nation. Ladies and gentlemen, talking about health is talking about life. I challenge all of us to reflect and put high premium on ethics around health. I challenge the health professionals particularly because they deal with life every day. But a man is ethical only when life as such is sacred to him. Ethics too are nothing but reverence for life. And the fundamental principle of morality is that good consists of maintaining, promoting, and enhancing life, and that destroying, injuring, and limiting life is evil. With these remarks, I want to reiterate my pleasure for having you here tonight at the University of Nairobi and invite our partner, the Nation Media MD, to come over and make remarks. Thank you very much.
Thank you very much, Professor. Professor Kivutha Kibwana, His Excellency the Governor of Makueni County, His Excellency Professor Philip Kutima, the Deputy Governor of Kakamega County, Professor Peter Mbithi, our host, the Vice Chancellor of University of Nairobi, Mr. Siddharth Charti, United Nations Resident Coordinator, Her Excellency Mrs. Sunchira Durai, the High Commissioner of India to Kenya, other honorable members of Parliament and Senate, our other panelists, Dr. Rudy from the World Health Organization, Dr. Githinji Gitahi from AMREF, Nelly Bosire, consultant specialist, Dr. Kihaki Kimani, senior lecturer, University of Nairobi, and Dr. Rashi Ahmadi. Our sponsors, the University of Nairobi, Bill and Melinda Gates Foundation, NHIF, the World Health Organization, Maidawa, Minet, Vilgro Kenya, AMREF, and Homeboys. Distinguished guests, ladies and gentlemen, good evening. It is my honor and pleasure to welcome you all to the 5th edition of the Nation Leadership Forum. This forum was launched in the year 2017 to provide a platform to provoke discourse, encourage dialogue, shape policy directions, and propose practical solutions to issues that are critical to the development and the growth of our country, Kenya. The success and value of universal health coverage depends on its ability to provide safe, effective, quality, and affordable health services to all people everywhere. We are in a new era where the quality of health services has taken center stage in the pursuit of health-related sustainable development goals. We are glad that the Government of Kenya, in partnership with various development partners, has sought to entrench the 3rd Sustainable Development Goal by prioritizing universal health coverage as part of its Big Four agenda. It continues to be a concern that majority of Kenyans cannot afford the high cost of treatment and medication. It is in this context that the series seeks to catalyze discussions and seek solutions to address access to health, to address the human resources of health, and health financing. We are grateful to the many experts, both on the podium and in the audience, who have come to share this knowledge with us today. I wish you all a fruitful deliberation. Asante sana, and God bless you. Thank you.
With that, I now want to quickly introduce my panelists right up on stage. Beginning from my far right, I'd like to introduce Dr. Rudy Eggers. It's actually called Rudolph, but you just call him Rudy. For tonight, Rudy Eggers is the resident representative of the World Healthcare Organization, that's the WHO. He has a great experience in providing services and providing technical support, that's the government of Kenya, and also a trusted hand in immunization, having worked in Geneva for over 11 years. So we're honored and glad to have Dr. Rudy Eggers with us up tonight on stage. Can I appreciate him? One clap, please. Next up, I'm going to introduce Dr. Rashid Aman, who's the CAS, that's the Cabinet Administrative Secretary in the Ministry of Health. I should mention to our viewers, of course, you saw on our promos and also on TV and on papers that we also had CS Cecily Karaoke. We had invited her to come, but we have her right-hand man, that's Dr. Rashid Aman, to represent her on stage. So let's give a round of applause to Dr. Aman, please. Next up, please let me introduce Dr. Nelly Bosire. She has over 11 years as a practicing gynecologist, especially interest also in health advocacy, having also represented at the Nairobi chapter at KMPDU, and also a board member at the Kenya Medical Practitioners and Dentists Board. Thank you for being here. Next up is His Excellency Professor Kibuthe Kibwana, who's the governor in Makueni, an old and respected hand in politics, having worked, of course, as an MP, Minister of Land and Environment. And he actually mentioned that he was lecturing here over 25 years ago, sir. Thank you so much for being here. So one more round of applause, please, to Professor Kibuthe Kibwana. Next up, let me also introduce Dr. Kahaki Kimani, who's a senior lecturer in the Department of Ophthalmologist right here at the University of Nairobi. Having had, of course, 2 degrees, 2 master's degrees in her area of specialization. She specialized in ophthalmology in the country and across Africa, and has a passion to actually have children access healthcare if they can pay for it and if not. Thank you so much for being here, madam. Next up, let me introduce Dr. Githinji Gitahi, who's the Group CEO of Amref Health Africa. He's also the co-chair of the Universal Healthcare Coverage for 2030. That's actually a working group by the World Health Organization and the World Bank, having also been a passionate advocate for pro-poor and primary healthcare, and also previously being a director at SmileTrain, NMG, and GlaxoSmithKline. Thank you so much for being here. And thank you also to our panelists for making time to be here on the National Leadership Forum on Health. I'm going to jump straight right into it. I'm going to come to you, Rudy. We have, of course, the overall plan, the big 4 on health. Let's go into the World Health Organization definition for universal healthcare coverage. If you just give us the 4 points into how you drill down UHC.
So thank you very much, Laban, and welcome to our viewers. So the World Health Organization is the prime UN agency that deals with health. And UHC is actually, universal health coverage is actually central to our program. What is UHC? Well, it actually means that all people, be it in Kenya, but really across the world, will have access to basic health services that are of high quality without suffering any financial loss. So central to the whole idea of UHC is universality, everyone, and that people get quality services without having to pay out of their own pocket.
Dr. Aman, we target to have universal healthcare coverage in Kenya by the year 2022. Are we going to make this target or not? And what are your key points that you're looking at in the ministry to reach this target?
Thank you. I'd like to be optimistic and say yes, I think we can. It is indeed a great challenge. It's not going to be an easy one, but we believe we can if we do it well and we plan well. And the key areas that we want to look at are, 1, the financing aspect. How are we going to be able to mobilize resources to cover the populations that we want in a universal way? 2, we want to be able to provide access to health, accessibility and affordability as well. Access means, physical access, geographic access, but also access of patients to the services they need. And in that regard, we will be focusing upon strengthening health systems. Thirdly, of course, we want to be able to reduce the out-of-pocket expenditures for Kenyans seeking health, so that it does not continue to drive them into catastrophe, particularly those groups that are unable to afford health services.
Thank you. Dr. Bosire, do you agree?
Well, I think from my perspective is that we have a lot of gaps that we have to deal with. We have to be a bit realistic about that, but everyone needs to pull their weight. Speaking from the health professional perspective, I think probably the last 7 years have been very, very consistent in focusing on developing human resource for health in this country. We have seen our universities go the extra mile to expand the intakes, to improve the numbers of students we are graduating who are going to be our doctors, our nurses, our clinical officers. We need to now focus on making a concerted effort in retaining those people in this country to provide services if we are going to achieve the universal health coverage goal. And in the same respect, for the healthcare worker, there is no such thing as healthcare for the poor or healthcare for the rich. Every human being deserves the same quality of care.
All right. Professor Kivuda Kibwana, you're on stage because Makueni has managed to achieve universal healthcare coverage. Speaking on a county perspective, mention hospitals such as Wote, which you'd find, people traveling all the way from different counties to actually come into your county to access healthcare. How did Makueni achieve this?
It was actually quite simple. The young people...
Is that an agreement or is that a doubt? Okay, over to you, sir.
The young people who are in charge of health in Makueni, and actually they are, I think, under 35, the top people, they told me that if we did maths and we said the people come to pay in the hospitals, how much do they pay? And we said, suppose, we have actually 162,000 households, and we divided that amount. And therefore, they told me that if every household pays 500 shillings, we'll be able to get the money that usually everybody pays when they come to our facilities. And we exactly actioned that. And as a result, when our households pay 500 shillings per year, the father and the mother or mothers and their dependent children, 18 in school or 18 and below, or 24 if they're in school, they get free medical care in Makueni County. And we started with a pilot for 65 and above from May to September 2016, and it was working. And then we graduated everybody so that today those who are 65 and above don't pay, but everybody else pays 500 shillings, and we have about 70% coverage of that version of healthcare. And because of that, people get inpatient, theater, all that. And of course, we had to do many things to make sure that there is true facilities which people can come to and get treated. And so that's our story.
Thank you. Dr. Kimani, what's critical when you hear the governor speak is issues about affordability. And speaking into your passion of actually ensuring that children will actually access healthcare, whether they can pay or not, then ties a lot into that. If we just delve a bit deeper on this financing aspect as a critical issue in achieving universal healthcare coverage.
Thank you. As you have mentioned, I'm very passionate, especially for children, because when a child comes to hospital and they are turned away because they can't pay, you can see the tears in the mother's or the father's eyes. And I was very excited actually to see that Professor Kifuda Kibwana was on the panel, because I've been to Makueni and I have seen it can work, and at a very low cost. And one of the things I want to assure you is that the University of Nairobi, the College of Health Sciences, is very passionate about human resource for health. And I can guarantee you, we produce quality products. Our doctors are good and able, and we just need to put resources in place so that they are able to work, and also so that we don't get this brain drain to the private sector, to more lucrative areas, to other countries, because I think Kenya is blessed in that aspect, that we are able to produce the necessary human resource to ensure this universal health coverage.
Great. You mentioned HR. Allow me to just quickly follow-up question onto that. In ophthalmology, we actually take, for instance, the issues about the cost. This is a case study example. We have one ophthalmologist in Kilifi serving the entire region of the coastal region. And you mentioned about HR for health. And if you just look at that into kind of the deficiency, or should I say the lack of sufficient skill set and staff on the ground.
Let me start by saying that offering healthcare is teamwork. You need highly trained professionals, but you also need the mid-level cadre, and you also need the lower cadre, the cleaners, the cooks in the hospitals. And unless you have this team in cohesion, then you may have a very senior doctor posted somewhere and they are unable to deliver because they do not have the necessary support system. It's good that you have mentioned the issue of the coast region having only one ophthalmologist, and actually was just posted last year. That's when she qualified. And you can imagine the whole of that population not being able to access a certain level of eye care because of various lapses. Because it is not that there are not enough ophthalmologists to post to the coast region, but there are also the issues that surround the county system of health governance and health care.
Great, thank you very much. Dr. Githinji Gitai, there is a turnkey idea you have, which is all about strategic partnership agreements, strategic purchasing agreements, such that we should reframe our models of how we procure healthcare. Just delve a bit deeper onto that, into what work AMREF is doing, and also yourself as a representative in the UHC 2030.
Laban, first allow me to make a small correction to you. So say after me.
All right,
universal health coverage.
Universal health coverage.
Good. Not
Copy.
universal health care.
All
okay?
right, copy.
So please stick to that so that we follow the same conversation.
Sure.
The next thing I would like to say is that the idea you talk about of strategic purchasing is not a tanky idea. It is actually a very basic idea, exactly what the panelists are talking about, and specifically Professor Kifuda here, and what is done in Makueni. The first thing I would like to say is that universal health coverage is not about equality. It's about equity. It's about considering those left behind first, then bringing them to the table to reach the others, and then moving forward together. So I think that's really, really key, and it's important for the debate also that we don't diverge into why not 3 ophthalmologists versus 4 versus this. The debate, should focus on not leaving those who are left behind, about equity, about ensuring how we offer those left behind at everybody, equity, not equality. Now, when we come to that, then you then ask, the question you're asking is about purchasing. It's about who is buying, and they're buying what and from who. Now, generally what we have right now, and many of us seated here, purchase healthcare. We all purchase healthcare. When I'm sick, I go purchase healthcare. When my wife or my daughter is sick, I go purchase healthcare. So the purchasing idea is about saying, move to a place where you purchase healthcare strategically, or in a proper way that is thought before and planned. And that is where now we come to say, what do we need to purchase? What exactly, where are we going to purchase it from who, and how much? Right now, the wastage in the system because of lack of this strategic approach to purchasing is that many people purchase healthcare individually through out of pocket. That's wasteful. It's like you actually paying a teacher for your children every time they need to go to school. They have one teacher instead of going to a school where there are many teachers. That is strategic purchasing of education. So you're saying, how do we move healthcare to a place where we strategically purchase the healthcare needed? But first you have to take a step back and say, what healthcare do we need to purchase? Which is what brings us back to what we call the health benefits package. As we move towards UHC, we have to ask, what do we want to purchase? Then how do we purchase it? And how do we purchase, who do we purchase it from so that we get more health for our money?
All right.
Thank you.
Thank you so much, Dr. Gitai. You must have forgotten that I'm actually Mr. Laban Cliff. Now, with all the panel of doctors and honorables, I should mention, so we agree, universal health coverage. So let's just use UHC, right? Great. After this, I think I should graduate to the medical, and Professor Mbith is here. A medical degree, and let's just say Dr. Laban Cliff. When we come back after the break, we'll have more details. Now hearing from the Mwananchi perspective. Most of you reached out to us and said, hey, let's also have diversity of opinion and just let's hear what the Mwananchi has to say. When we come back, we'll hear from the Mwananchi. Stay tuned to NTV. This is the National Leadership Forum coming to you live from the University of Nairobi, the second session where we continue to just delve deeper in this issue of health. And just before we proceed on with the deliberations right here at the University of Nairobi, allow me to just take you through some of the concerns that we got from Mwananchi just coming up shortly. Let's take a listen and we'll back to that.
When I hear health in Kenya, I think about costs, how expensive it is.
We need the government to focus on the quality and the skills of the personnel.
Delayed treatments, poor referral system within the county.
Hospitali zetu hazina madawa.
The cover ya NHIF inafaa kwamba ikuwe inafikia kila mtu na isaidie kila mwananchi.
If the government can chip in, you find that they are paying certain amount, maybe in the pharmacy level or in the consultation level or in the lab level, any level, you know, if they can chip in something, it can help.
Key issues that came about in those concerns raised by Mwananchi is the issue about NHIF and how do we really ensure that NHIF lives up to its billing as being a key driver of UHC. So we have the NHIF CEO shortly. He'll be coming in, just giving his quick remarks and of course addressing some of those key issues that were brought up. But just a quick comment from the panelists. First, Rudy, it's not easy or it's not being felt, especially in the country right now where, you know, you go into the rural areas and you still do not get residents receiving, you know, healthcare to the core level. So from the World Health Organization, I don't know, what are some of the key advices that you actually give to government, which is actually the work that you do?
So thank you again. One of the key aspects of universal health coverage is access to services. So as you point out, in many areas of the country, that still has to be built further. And this is not only the health facility, it's also the health workers, very importantly, to have, when you come to the health facility, somebody there that is qualified, that is knowledgeable, that is able to treat you. You have the right equipment there, and you have the means to refer these people to other facilities, to higher facilities, if necessary. So from the World Health Organization, we've got some guidelines on how to build that, also some standards according to which countries can measure themselves in building their health systems.
Thank you. Dr. Mann, let's just address this issue of Cuban doctors once and for all. You know, it keeps coming up, and statistics that I have so far is that 171 have already been deployed into the county level. This, we're told, is a bilateral agreement between our government and that of Cuba. So how did you come about this and leave out your own jobless while getting doctors from abroad?
Thank you, Laban. First of all, I want to correct you. The number of Cuban doctors that are now in the country is 100 and not 171.
All right. The 100.
2 per county.
Okay.
I think the debate has been on, of course, in the public domain. We have, as a ministry, have brought in these doctors because we felt that there was a need for specialists, particularly. And I want to clarify again that some of the information in the media is not absolutely correct, because the doctors who have come into the country are specialists. They are doctors who have many years of experience in particular fields. You yourself mentioned the problem with specialists in some of the counties, particularly in the remote and far-flung areas. As a ministry, we knew that we had a serious gap in some of these areas for specialists, which the Kenyan population need. And indeed, we do have Kenyan specialists as well as Kenyan doctors, but we are far, far from the World Health Organization norm for the ratio of doctors to population. The norm is about 35 to 36 doctors per 10,000. I think we, as Kenya, are ranking at about 15 to 16 doctors. So we have a long way to go. There is a real gap. The issues that may confuse us here is distribution and where some of these specialists would want to practice. I also want to say that I think most of us recognize that our own specialists most of the times establish their practices and practice within urban settings.
Thank you, sir. Allow me to just cut you short at that point, but Dr. Busire, just kind of draw a balance for us. Here we are, we want to meet the WHO requirement of the ratio of doctors to the patients, but at the same time, we do not have a lot of specialists locally to actually meet this. But then you complain that, the government is overlooking the local doctor.
As I said before, if you look at from 2011, the trend that has been going on has actually been going on very well. In 2011, when the union first went on strike, our doctor to population ratio was 1 to 17,000 people. Currently, as we speak, we are at 1 to 5,300. If you look at gains in 7 years, I would say that's marked. So we don't know where we dropped the ball to the point where the government felt the need to import. But if you're going to talk to the colleagues here who have talked about universal health coverage, UHC is not driven by specialists. It's driven by GPs. Okay? And GPs, because you're talking about a basic package. And basic package is that you want every Kenyan to access a GP, and that GP then makes the differentiation on whether the patient actually requires a specialist or not. So where we're sitting, we have 2,000 GPs we're wasting. Okay? Who are the ones who need to be in these spaces? So at that point, it won't matter where the specialist is, because the referral systems should actually work. Everywhere in the world this happens. We know in the US, you will have a child with an anomaly in the heart. They're not going to get treated in their little county. They're going to be referred to a university hospital that's probably many, many miles away. So in Kenya, we appreciate the gap of specialists. We've had more university aggressively come in to train more specialists. We've had Aga Khan. We have had Kabarak University. Maseno University is actually training family medicine, a lot of whom we have imported, alongside Kabarak and Moi and a lot of others. So we're making progress, and we probably would want to push that alongside anything else that we are going to bring in.
Great. Governor, I'm going to come back to you, of course, the rest of the panelists. Just let's get a quick intervention from Siddharth Chatterjee, who's, of course, call him Sid, who's the UN resident coordinator. Just give a quick input onto, how do we actually get to achieve this in the road towards universal healthcare coverage?
Well, first of all, I want to applaud the government of Kenya for having taken the decision of universal health coverage. That's a bold and courageous decision at the very outset. Not easy to do, as Dr. Rashid Aman said, but today, we are in a situation where we have the technology, we have the innovation, we have the human capital here in Kenya to allow us to leapfrog. So if you're asking me, is it possible to do it in the next 5 years? Absolutely, yes. I have seen what has happened with the drop of maternal mortality ratios in counties like Mandera and Wajir and Marsabit and Lamu and Isiolo, which used to contribute to 50% of the maternal deaths in this country, and they have been able to reduce it by 1/3. If you look at 2014, the maternal mortality ratio of Kenya, it was approximately 488 deaths per 100,000 live births. That has now dropped to about 366. I really believe Kenya should compliment itself on its back. It's not a doom and gloom story. It's a story where you're making rapid progress. So, and today, here is a fact to all the doctors present here. It's a profession which I greatly admire. Kenya, like the rest of Africa, is 50% short of doctors. And that gap is going to increase. By 2030, Kenya's population is going to be close to 65 million from the current 46 million it is. And by 2050, it's going to be 90 million. You can try your best with the number of doctors you can bring in. It's not going to, the numbers are rapidly increasing. What you also want is an army of tech-savvy community health workers at the ground level. Improve preventative health, improve immunization, improve prevention of waterborne, vector-borne HIV, TB, improve upon maternal and child health. The first country to actually go for free maternal health care policy in sub-Saharan Africa, and the rapid progress it has made. Improve upon lack of access to NCDs, particularly hypertension and diabetes. That is something which could bankrupt the NHIF. We have to look at preventative side, behavior change, and let's improve on nutrition from the time a mother conceives to the first 5 years of a child's life. We get this right, Kenya by 2022 will achieve UHC, and I guarantee that.
Thank you very much. Thank you, Sid. Geoffrey Mwangi, CEO of National Hospital Insurance Fund, that's NHIF. You're very critical in this discussion because, you know, but at the same time, because NHIF is the driver towards UHC, but at the same time, there are concerns and the questions coming out into that NHIF, is purely favoring, the high-end hospitals, not really getting to the grassroots level. The payout ratio, especially concerns amongst employers, is that, it's a bit skewed. So just quickly address these concerns that Kenyans are raising.
Thank you very much, Cliff. Just to correct that is Mr. Mwangi, just like you, not Dr. Mwangi. And thanks for this healthy debate. Yes, we still have this sticky issue that to drive the enrollment of NHIF to the informal sector is challenging, not only in Kenya, but throughout the world where we have the biggest population in the informal sector. Currently, we have a membership base of 7.6, and we still have, about 20 million Kenyans who are eligible NHIF members. So we have a gap of about 12.4 million principal members who should be enrolled to us. This has picked up since the whole of last year, and especially when we made the decision that UHC should be attained by 2022. And this has seen very high enrollment. And as you can hear people saying, yes, when you reach that point of seeking services and we realize how much the NHIF card can be of value is when people start rushing. So it's a debate we need to continue having and educate our people that it is important to have this card by yourself. We still have a couple of challenges, as you're saying, about a payout ratio. We are still reforming the benefit package to see exactly how much do we pay out, how much do we address, how much do we give out as services. But I would say this from where I sit, the drive is good, and I can see a lot of improvement in the days to come. Thank you.
Dr. Amit Thakkar, CEO of Kenya Healthcare Federation, of course, the private sector arm representing, this sector. What's your reaction to Mr. Mwangi's comments?
Yeah, thank you. That's why you made me sit next to Mr. Mwangi. So there we. But to be honest, the private sector in Kenya fully supports UHC. But there's a clear message that I want to give for the discussion we've had. Just 3 or 4 points. One, UHC is a process and not an event. If we lose our patience with the leaders and the stakeholders that are here and are listening, we might lose the ball. So let's do it correctly rather than quickly, so that eventually we find generations that have better healthcare tomorrow than what we have today. That's the first step. The second one is, let's be inclusive. It's not about we are going to close public, or we are going to close private, or we're going to close the faith-based organizations or support one or the other. I think together we are stronger. Let's build our local capacity and local industry. Third, it might be too risky to just bank on one unit. I was talking to Mwangi that NHIF could not be the only one that we should count on. As we strengthen NHIF in its weaknesses, as you've heard, and from the kind of challenges that we have, why don't we just use the solution that's right in front of us, county number 17?
Thank you. Thank you, Amit.
Laban, as I'm saying, if county number 17 has shown they can do 70% in a short time, let's replicate it and take it throughout Kenya. Let's bring healthcare closer to the people by replicating what works. Cost-effective coverage that Makueni has set the trend. Congratulations, Governor Kibwana.
All right. So, Professor Kivutha Kibwana, let me just get your quick reaction on that. Advice to counties, because did we lose it when we devolved healthcare to the counties? Was it a disaster with all these concerns that are emerging? And how is Makueni different?
Well, I think just as was stated about, for example, maternal deaths, the way in which, in particularly the northeastern counties, that has changed drastically. I think devolution, for me, has really made a radical change in healthcare delivery in the country. And there are many firsts. It's not just Makueni. And indeed, even as we have our own version of universal healthcare, we're also thinking of getting it to NHIF and making many of our citizens also become members, because when they have to go to hospitals outside Makueni, Makueni Care doesn't cover them. It covers them within Makueni. But I think there is also a challenge, and I want to throw this challenge. In terms of the monies that NHIF pays, I think like within a year, maybe roughly about 25B. The bulk of that goes to the private institutions, and then the mission hospitals, and at the bottom, public institutions. And for example, I was surprised to know that when we do a cesarean section in Wote, in the public institution, we are refunded like 5,000 shillings, Linda Mama. But a private hospital in Wote will be 17,000 shillings. So I think there is, as the president has said, there needs to be drastic reform of NHIF. I know that it is going to be a principal player in terms of delivering universal health care, but I think we really need to scrutinize it very carefully so that it can deliver this one of the 4 agendas of the president.
When Governor was speaking, I was hearing a lot of mamas in the room. What are those about? Somebody wants to quickly comment. I'm told we're going to take a break and then come now to the plenary session where you can just quickly hear from the audience. But of course, I have to finish with my 2 panelists before we come to the panel. So stay tuned to the National Leadership Forum. Keep, of course, reaching out to us with the hashtag NMG Leadership Forum, where we can also get your deliberations if you're tuned to us from at home and, of course, across the world. Stay tuned to NTV.
evening. Here's a quick look at some of the stories our newsroom is working on at this hour.
Solai Dam owner charged with 47 counts of manslaughter as he and his two co-accused are denied bail.
Should be any different. There's no reason why one should have a swimming pool, the other one has a sauna, the other one has a boxing ring, those things. There is no reason to have such discrepancies.
Senate wants monies for non-core functions withheld as counties ask for more allocations.
Hii barabara nani atapitia hapo? Si ni watu? Kwani barabara itakuwa ni ya magari tu ndio wanatengenezewa?
Kibra residents demand compensation for road construction amid reluctance to pave way for the highway.
Police arrest two IS terror group suspects in what they say is a family business.
Well, details of these and other stories coming up at 9 p.m. For now, we cross you over back to the University of Nairobi. But for now, some commercial break and then that health conversation.
Sensitivity.
Sponsors.
Greetings. You're watching the National Leadership Forum. My name is Laban Clifford Siro, still coming to you live from the University of Nairobi. You notice I actually stood up because now it's a session to have a plenary discussion. We really want to hear the concerns from the live audience that we have right here. So we're going to start with KMPDU. You're going to introduce yourself, sir. Just say your question to which directed to in just under 30 seconds, please.
My name is Dr. Chibanzi Mochonda, the Deputy Secretary General of KMPDU. We also have the Chair, Dr. Oroko, and the Secretary General, Dr. Luga, in presence.
To the question, please.
Yes. The question I will focus on is on HRH. And let me just set this record straight first and clarify something about the Cuban doctors. We have 50 family physicians and 50 specialists. The family physicians are almost equivalent to the GPs we have in the country. We have 2,000 unemployed GPs, pharmacists, dentists. We have 171 specialists that are unemployed. So the question is, and I'd like to direct this to the Cabinet Secretary, the CAS, the Cabinet Administrative Secretary, is the government willing to engage and declare, or rather to absorb these local trained doctors in as much as we are building capacity by bringing in foreign doctors?
Thanks, Mochonda. Let's leave it at that. At the risk of only making it a case of doctors, we also have trained nurses in the house. I see that's the Kenya Medical Training College. Let's say KMTC, yes. Let's have a representative please give us a comment from KMTC. Just get a quick comment from that. There's a gentleman there in the red blazer. Yes, please kindly pass it on. Sorry, to this gentleman. Yes, kindly. Thank you. In just under 30 seconds, please introduce yourself and choose your questions there. Yes.
Well, I'm Shadrach Yego from Kenya Medical Training College. I have a lot of questions, of course.
Just 30 seconds, please.
Just want to to have one. Mine is direct to Dr. and Professor Kibwana. Actually, we actually appreciating the fact that you embraced the UHC. And I would also want to ask, is it possible and simple the way you said, for you to at least sub-devolve the paramedics, because we realize that there is one thing that is actually a problem in the county levels, in as much as we're trying to move from because we had the MDGs and the SDGs, we've rushed and we've not accomplished the primary healthcare system. Now we're having the all coverage, but you realize that some homestays do not even have some sanitary and hygienic things that would have actually helped the nation in terms of curative and preventive measures. So is it possible for you to actually do it from sub-county levels and ensure that in each and every department, right from the ophthalmology, OT, nursing, is it possible for you to employ more and so that we actually devolve it more? Thank you very much for that opportunity.
Appreciate it. Thank you very much. I just want to get a diversity of audience. We also want to make sure we can hear. Ruth, you're here with Madam Florence. This lady I know is based all the way up in Nyanza region. Mama, tafadhali naomba uzungumze kwa niaba ya kina mama ambao wanataka matibabu kule nyumbani. Tafadhali.
Good evening, viewers. Thank you. First, Laban, I want to, before I say anything concerning women, I want to ask the PS Minister of Health that people are willing to contribute to National Hospital Insurance, but they fear to put their money there and it will go to somebody's pocket. Secondly, few seconds you gave us to talk about is not enough. Secondly,
just try your best, madam.
No, I'll not try because I have to say things which people will understand.
Yes.
Second,
all right.
When people in back home all over the country, I don't say only Migingo where I do come from, but parts of the country, you don't go out and tell people how best they are going to get when they pay for the National Hospital Insurance. So people are still wondering and fear that they might put their money in national NYS iende kwa mkono ya mtu.
Thank you, Madam Florence.
Again,
thank you.
Ya tatu, ya tatu,
I'm just giving you
Migingo is very far. You know, I sailed up to mainland, so I have to finish
Madam,
my question.
Yes.
The last
now, yes,
is when you go to Migingo, you are going to you take these Cuban doctors. Will you teach the Jaluo, or you teach the Cuba, or what are you going?
Thank you.
Surely.
Thank you.
Asante sana, tuarudi
It's a
sana.
good way to stop it there. Thank you very much. Thank you. Thank you. That's Madam Flores from Migingo. So, Tony Woods, telemedicine, just a quick comment on telemedicine, please. As I know where the mic is gone. Yeah, Tony Wood, please go ahead from my down. Yeah.
I don't know how I can follow that, but let me just change tack slightly. We've been talking a lot about accessibility, cost, and quality, but really what we need to look at is how we achieve those things on the budgets that we have today, because that's the reality of where we are, and how technology can play a role in that, in terms of gaining efficiencies from the resources that are there today. We've had lots of conversations about the resources. We have how many we have in the country, and that's not going to change massively overnight. So how do we use technology to make those resources far more efficient and far more effective, whether it be in terms of telemedicine, telehealth, etc.?
Thank you, Tony. I was just looking out for the next session of panelists. Sorry, I'm just trying to get our floor managers to make sure the mics come to you. Dr. Kimani, just listening to Mama over here from Migingo, the concerns are real right from the ground level. I don't know, what is your advice? Of course, not touching. And I should mention that the issue of Cuban doctors was addressed, and I don't want to go into that. KMPD also has spoken. Oluga is here, but he's actually chosen his counterpart to speak. So over to you, Dr. Kimani.
Well, the issue of people's fear that their money will disappear, I honestly don't know what to say about that, but I think those are valid fears. And from where I'm coming from, I deal with children with eye cancer, and we have experienced a lot of challenges when it comes to NHIF. Yes, it has gone a long way in helping, but it reaches a point where they say no more. And you know, when you're dealing with cancer, it's a long-term illness. The parents have pulled their resources to pay up for NHIF, and suddenly they are told, we can't cover your treatment anymore. So her fears are truly valid. But I think there is a way that NHIF can package itself and validate themselves and truly show that they are able to live up to the expectation of the Mwananchi once they have contributed to the NHIF fund.
Thanks.
Yeah.
Dr. Gitai, at the risk of mudslinging NHIF directly, but as it goes beyond NHIF, I don't know, what are some of the other quick wins that we can actually leverage on?
Thanks, Laman. I think I would like to make one comment on the Cuban doctors and then close it there.
Sure.
And I think one of the things I would say is, I don't think anyone would have a problem if Harambee Stars was to buy Ronaldo, actually. The problem is that would make Harambee Stars go to the World Cup. So the thing is that you also have to invest in Harambee Stars, whether you bring Ronaldo or not. And I think that's where the people are having the challenge, that we have to build the entire health system, even if they come, and it's okay, they come and add to what we have. It's about, we have to think about the entire health system and rebuild it up. I think in terms of paying for healthcare, we have NHIF. NHIF is one of the tools, and I think for now we are saying we need to recruit people into NHIF. When you talk about how we can pay for healthcare, there are many forms of paying for healthcare. The government even now is purchasing healthcare for the people. We're doing Linda Mama, we have user fees that were removed at the facility. The question is about what are we paying for? I think that's what has not been defined. And if you remember the old story of Alice in Wonderland, it doesn't matter where you're going if you don't know what the destination is, which route you use. So we have to define what is it we want to purchase. And I think that's where NHIF is still struggling. NHIF has their own packages. They have packages that they have designed themselves, and that's what they're providing. But what is the government, what are we offering the people under UHC, which is pro-poor, those left behind first, equity-based, primary healthcare based? We define it, and I'm happy that the ministry is now doing that. Then we define how to purchase it, either NHIF, tax-based, whatever we decide. But that's what I would say.
All right.
Yeah.
Dr. Mann, I know you're burning to speak right now. Just address it, but hold that thought. Really quickly, let me pass on the mic. Okay, there's a mic there. Yes, please introduce yourself and who your question is directed to. Let's just sort that mic. Is it on? Just confirm. All right. Sorry, speak into the microphone. Yes.
Yes, that's what I'm trying very hard to do. My name is George Marenya. I have a simple thing to put to Governor Kivutha Kibwana and everybody in this room. The essence of everything we are talking about here, hearkening from what the Migingo lady has spoken about, is good leadership. I know in politics we don't use the word love. Love is found so much in the Bible. But do leaders love their people? What makes them wake up at night? I believe what makes Kivutha Kibwana wake up at night, the Kivutha Kibwana, the Karl Marxist, the Kivutha Kibwana deformed Machiavellian during Kibaki days, Kivutha Kibwana now the Max Weber. It is fundamentally one thing, that Kivutha Kibwana has love for the people of Makueni, and therefore he's always willing to go back home and send all the MCAs back home so that there is a new election in Makueni, if that is what it takes. Therefore, it's a question of good leadership, period. Simple, end of story.
Thank you, sir.
Now, lastly to Dr. Bosire.
Shortly, yeah. Sure. We're just going to come back.
The leaders of doctors who are here. I put it to you that there is something in the Kenyan doctor that is fairly mercenary. This mercenary streak in the Kenyan doctors, what do you think about it from your heart of hearts?
Thank you very much. Honorable. I need to make sure the title is there correctly. Honorable Nyokabi, please. You have a solution and there's a bill in Parliament that you're looking towards doing in terms of creating centers of excellence. Quickly speak about that.
Thank you so much. And just to say, it is indeed true that the leaders of the country think about the people. And when you're in Parliament, you receive many, many requests for Harambes for people who need healthcare. And those cards stress you, those cards put you under a lot of stress. And the members of the Health Committee who are here can appreciate the reason why the President has started this in early on. In fact, our deadline is not 2022 because 2022 is an election year. The deadline is 2021, that these things have got to be done before we proceed to the next election. And that we're having this conversation early on is very helpful. Boresha Maisha, which is the organization I and a colleague here, Kajuju, have established working with parliamentarians and especially the Health Committee, is looking at 3 solutions. One is the transfer of functions. That the law, the constitution, should allow a governor, especially those with level 5 hospitals and are struggling, to transfer it back to national government and have the national government take care of that function where the governor is struggling. Number 2 is the regional referral hospitals. Counties, including my own in Nyeri, are struggling so much with the level 5 hospitals, can barely manage to sustain the services required of level 5 hospitals. In fact, in some counties, unlike what we have in Makueni, our healthcare has gone down after devolution. Instead of healthcare improving after devolution, healthcare has actually deteriorated within the devolved system. So that those level 5 hospitals need to be created into regional referral hospitals and taken back to the national government so that we stop putting everybody into Kenyatta National Hospital as far as referral systems go. Have many more referral hospitals across the country. The level 5 hospitals are 11 in different counties, have all of them spread out. The third one, which is what I want to end on, is the Health Service Commission Bill. That our health professionals have a place and have a commission that addresses health concerns and health issues just like teachers do. Honorable Patrick here, who is next to me, is going to be championing that bill in Parliament. If possible, the health professional function should go back to national government. But even as with the commission, the issues of health professionals that all the cadres can now begin to be addressed within that commission, and that commission can negotiate with government, that commission can negotiate with the county governments, and that way we are better able to move the country forward. We have 4 years of doing that. We think that this parliament is going to give those solutions. Thank you.
Prof, let me get a quick reaction to that. Counties have not maybe lived up to the billing in terms of just managing healthcare in the devolved unit. And now with that bill, we hope that it will now go back to the national government. I want to get a quick comment and also go into Doctor also give a remark.
Yeah, I think the question about getting staff at a very low levels, health staff, I think that's a very important question. For example, in Makueni, before deciding that we could go the way of universal health care, we had to look at the facilities that we had. We found 109 facilities. We built fresh ones so that now we have 233, including 9 hospitals and even theaters, so that we have about 11 theaters, also new ones. So and we employed like 500 extra people. We found 977, and now we have almost 1,500. So there is that preparation, and we made sure that there is money for drugs, and that's why we have a very good relationship with KEMSA. We pay for our drugs, and many counties are encouraged to do that. So there is an array of things that you must do so that you can have a realistic healthcare. I think if you transferred healthcare back to the national government, you would have a problem with Kenyans, because they are now used to getting healthcare close to them. And in many places, it is different from before. So I am a bit nervous about that push. But I think, first of all, do public participation and ask Kenyans, is that what you want?
Thank you so much, Prof. Really quickly, let me get Dr. Mann. Creating centers of excellence, will that be the solution?
I'll come to that. Can I respond first of all to and close the Cuban issue?
Okay. Yeah, there you go. Please, go ahead. Yes.
I want to respond to the gentleman from the union, Doctors Union. Yes, indeed. I think we have overplayed the Cuban issue. It's only 100 doctors that we have brought in who are specialists. It's a short-term measure in order to provide services that are much required out there. And so, yes, human resources for health is a critical and very important part for us to achieve UHC. We are very aware of that, and we're working towards how to improve the level of human health care, how to raise to the standards that are required. It needs a lot of work. It requires a lot of, it's resource intensive, and the Health Act that has been alluded to will also address that in a wholesome way. In terms of service delivery, and I want to respond to my colleague on the issue of specialists, the aim of achieving UHC is to strengthen the chain all along the line. As a government and as Ministry of Health, we have invested heavily in trying to bring health services, quality health services, closer to the people. You are aware about the managed equipment services, which has equipped 98 level 4 and level 5 hospitals throughout the country. We have invested in equipment there. This also relates to the question of how can we use new technology to be able to solve some of our problems. Some of these equipment that have been invested in those facilities are imaging equipment for radiology. And in order to be able to have those services utilized optimally, we are also investing in linking up all these facilities through a communication platform that will be able to allow real-time diagnosis of some of these images, telemedicine. A specialist sitting in Nairobi.
Dr. Mann, I'll put to you that some of this equipment, I'm told, other hospitals are actually gathering dust because of lack of specialists to to actually use them to advance healthcare?
I'll answer that one.
Hold on that thought. Hold on that thought. I'm going to come back straight out to you after the break. So we're going to take a quick break only on NTV, where we come back on the National Leadership Forum. Now we're going to be looking at way forward. So no more issues. It's all about way forward. How can we address this issue about healthcare, and of course, as a Big Four priority plan, only on NTV. Stay tuned. Thank you. Welcome back. And this, oh yeah, you can clap for the audience that has just joined us. Thank you. Welcome back. This is the National Leadership Forum. My name is Laban Clifford Serio, still coming to you live from the University of Nairobi. We've had a myriad of issues that have been brought forth, discussed them. Some we haven't finished, but this is a session for purely way forward and how we can really address the concerns that were raised. Before we went on a break, we had a chat with Dr. Mann regarding the equipment that are lying idle, which have been contributed by donors from far and wide due to lack of specialists. Quick reaction onto that.
Thank you. I think the equipment we were talking about is the Managed Equipment Services, which is a program that the government has invested in terms of providing sophisticated equipment to the counties that they can be able to up their facilities and provide services closer to the people. You hear a lot of things. The information that we have is that most of this equipment is actually functioning because of the manner in which this equipment were acquired. There is service provision linked to it. There is training linked to it by the providers. And they are providing that, as far as we know. There may be a few isolated cases of equipment probably not being installed in certain places for lack of either power or proper water and all of that. And I think those are isolated cases. But in general, their investment is paying off. And I think it will be a matter of time before we see the dividends from that. One thing it will do is it's going to decongest our referral hospitals. Right. So I think I will stop at that for the sake of time.
Dr. Busiri, any reaction you'd have to have about the lack of specialists to actually operate the equipment at the grassroots level?
I think the managed equipment scheme is big. It's really big. And as a way forward, I think it's paramount that if we're going to achieve UHC, the first thing we must do is we must curb wastage. Our resources in healthcare are already quite limited. Now, UHC is one example of major wastage. We acquired this equipment and immediately started paying for it. But it took many counties 3-4 years to get them operational. In that time, they've been paying for a service they're not using, and 7 years the contract expires and this equipment goes away, but the Mwananchi has really not seen value for taxpayers' money. So it's critical that when we're looking at these things, we need to be a little bit more involving with the end users. The patient needs to say the service you're providing to me is actually acceptable to me. Don't just give it because it's donor-driven or it is a decision that has been made at national level. The county that's receiving it needs to say, at this point, I'm ready for it. If I am not ready, let's hold it back, pump those resources into what that county particularly needs. If their primary health care is struggling, having a CT scan machine is not going to help them. The second issue I'd like to talk about is access. And having institutions, having doctors means nothing. Makueni is not successful because they paid 500. Makueni is successful because first as a county they agreed they need to invest and then acquire the human resource and then ensure supplies are constantly available. Her question from Migingo is very valid. I give NHIF, I go to my local hospital, I'm given a prescription but the drugs are not there. When I go to buy them outside, you've robbed me, and that's a crime. That's how Mwananchi is feeling, and that's what must be addressed if you're going to talk about access. The last point, what about bringing in the other sectors that must support healthcare for healthcare to work? Water provision is doing terribly. The sudden sprouting of towns across this country has actually made us realize we don't have access to clean water. Security. Kapedo is still crying. It doesn't matter which nice hospital you build there. If they can't reach the hospital because they're scared of insecurity, we're not making progress. So we really need to look at access.
Thank you. Thank you, Dr. Busiri. Before I go into Vilgro and get a quick way forward from them, Rudy, I want to engage you here because I know you're very passionate about preventive and promotive health, because what the risk we run into is that saying, you know what, we always focus just on the end, this other end, but not really in terms of enhancing people how to, even live a healthy lifestyle.
Thank you very much. Yes, you're right. I'm quite passionate about that. So let's think about affordability of healthcare. Actually, the affordability of healthcare is in the preventative and the promotive area. So if you think about investment in things as basic as water, as road safety, as screening for high blood pressure, these are things that are truly cheap. And they're much cheaper. It's much cheaper to treat a person for high blood pressure than to treat them for the stroke and putting them in a high intensity care unit. So in terms of affordability, the key aspect that Kenya is doing right at the moment is to focus on the primary healthcare services, because in fact we know the level of the services get increasingly expensive. The higher you go, the more expensive it is. And it means that if we can get the primary healthcare services properly funded, properly staffed, properly with commodities, we can deal with 80% of the problems. 80% of the health problems in the country can be dealt with at primary healthcare level. We've talked a lot about specialists and about managed equipment, but that is really the key. That's where we have to start.
All right.
The affordability is at the preventive and the promotive area. I come from the immunization program. Just imagine this. You give the baby 2 shots and they're protected for life, forever. With 2 shots, that's a wonderful drug.
Thank you very much. Dr. Robert Karanja from Vilgro. Let's get your quick reactions and the way forward. You have the mic.
Thank you so much. So I believe we've all talked about all of these challenges and also the opportunities. And I'm especially glad that we're having this discussion here at the University of Nairobi, because health is one area that requires to be taken outside of the boundaries of doctors. We've talked about the managed equipment system that in some places is just cropping. Why? Because we are taking technologies that have been designed to be deployed in industrialized countries. And we are taking round holes and trying to ram them into square pegs, into round pegs into square pegs, yeah? And thank you. So, and how can we be able to address some of these issues? It basically means that there is an opportunity. The School of Engineering, that's your clarion call. You should be saying, how do we invent technologies for this economy, for our own primary healthcare? Because again, the other issue is that we've talked about the referral system. The primary healthcare will also need new technologies, new tools for the doctors to use. And lastly, we also need to have entrepreneurs. We also need to be able to think to ourselves, the economists, how do we get more with less? Where do we get the savings? And so let's open up this discussion about universal health coverage. It's not just about doctors and nurses. It's really about us and asking ourselves, what stuff do I hold in my hand? And what can I contribute to this issue?
Thank you very much. One more question and then I'm done with this side. I'm going to go to the side, please. Okay. Just go ahead, please.
My name is Dr. Nyanchama Masi. I'm the National Secretary, Kenya Association of Radiologists. So I really like the fact that you've brought up this issue of managed equipment services. Now, we're talking about equipment. We are the end users of that equipment. We are the radiologists. We are the imaging specialists on the ground. I think you need to involve the professional societies in decision-making and resource distribution. We have done very well with Mr. Mwangi, NHIF, who has really incorporated the professional societies in these decisions. Remember, we have economic concerns. You have 37 CTs coming in at almost double the price or triple the price. All right, is there justification of the cost? The other thing is safety issues. I like that Daktari has talked about children and you've talked about cancer. Now, I'd just like to give you the enormity of radiation. Remember, there is radiation risk to the public, number 1. There's radiation risk to the patient. Number 3, there is radiation risk to the worker. One CT scan will give you an equivalent of 500 X-rays, just for a simple CT scan of the head. The effect on a child is 10 times that on an adult. Please involve the professional societies. We are here. We are grateful for those who are using us, and also create a system where you're able to train and retain people. When I was studying, there were only 11 radiologists in the county, all right? How are we able to train people? You can do online studies, but who will maintain the standards on the ground?
Thank you very much. Appreciate it. I'm done with that side. I still also need to get from Dr. Frederick Onyango. I think we just make sure you can pass that mic to him. Just let's hear also from the Mission Hospitals. You're a chairman and founder, I'm told, of Shalom Hospitals. But before that, Dr. Nyikal, please, your quick way forward. Over to you.
let me tell you. UHC must work. One, the concept came from here. 2005, when we have the National Social Health Insurance Bill that was passed in Parliament and not accepted to. In 2005, on the 58th WHA, World Health Assembly, this was discussed, and that was the origin of UHC, when Kenya, Brazil, and Thailand brought it out. If you Google it, you'll find it. Two, Kenya as a country was able to have a working health system. 77, 78, we were transferring patients from Aga Khan to Kenyatta. We were treating Minister Kenyatta. 78, I was transferring children from Aga Khan in Kisumu to what was then called Russia. Fast forward. What we need is one. Primary health care, primary health workers, control of preventable diseases, and promotion for non-communicable diseases.
Thank you. All right.
Two.
Yes.
Two.
Yes. Go ahead.
UHC does not mean complicated health care. What you need are, like Professor Kabwana has done, those what used to be district level hospitals, or what is now called level 4. Let's get all of them working so that the majority of people can then be treated there with what NHIF is offering even now. Then have a benefit package that is designed. This is the benefit package that NHIF pay for so much wherever you are, so that we do not have now NHIF subsidizing the private sector where they're paying more.
Thank you, Doctor.
Three.
Lastly,
we do
sir.
not
Yeah.
need to bring healthcare back. There was a problem of devolution implementation because the transition authority did not work. They now have the Intergovernmental Relations Secretariat. They are working on it that will link the two levels, and we are actually going to get this. Parliament, the Health Committee is looking. We are also not happy with the very expensive equipment we are buying.
Thank you very much.
Well, I don't
appreciate it. Dr. Sole, I see you. Please just hold on to that thought. I'm really under pressure to make sure that we can wrap it up, especially to our panelists on stage. I'm going to get a quick reaction from Professor Kivutha Kibwana, and then we can just follow it through, and then we can call it up on the end. Or let me have Dr. Kisai please start. Just go ahead addressing Dr. Nyikal's concerns about how we are addressing UHC.
I think I would like to start by saying that health starts at home. And I think that's where we get it wrong. I think this is the problem, is that we have an inverted investment in Kenya, where we're investing at the top, and at the bottom, we are not investing. Remember that the top killers in this country are still pneumonia, malaria, diarrhea. None of those requires some of this equipment that we're investing in. So we need to change, Bwana CAS. We need to change our investment model so that we take money back to the bottom. Because if we don't do that, it doesn't matter how many hospitals we build, we will never satisfy the demand, because it's like a river flowing down. We have to take the money back to the bottom. Now, that means that we have to focus on people called community health workers. Community health workers in this country continue to be volunteers. We have volunteers. They're not even volunteers now. They're the ones funding mothers to go to the hospital out of their pocket, and yet they have no money. We have to focus. We have to employ them, make them part of the health system, build up to nurses or the auxiliary services, then doctors, upwards. That's what we have to do so that we can actually achieve UHC. So that, for me, is what we must start with. We must start at the bottom and build upwards. Thank you.
Dr. Kimani, key takeaways from you, please.
I think the government must learn to consult the people who have the information, so that when the decisions are made that affect the whole population, then they are the best decisions for the population. And we have very experienced professionals being consulted internationally. but when decisions are being made, other international consultants are consulted who have no idea what is going on in Kenya. And so we must make better use of the human resource that we have.
Governor, last but not least, thank you. Over to you for the closing remarks from your side.
I think because the Constitution says health is a county function, first and foremost, I think that needs to be respected. And therefore you may change law and it is against the Constitution. As far as the equipment, there was a problem because there wasn't actually consultation. Some of the governors had already bought some of those equipments. And it is true, the training aspect was not factored in, initially, and we thought they were quite expensive. So I think that kind of consultation is important, and it is also a good thing. The community health strategy, that is something that the country needs to look at together. That is so primary, and it will help us a lot. And finally, in terms of financing, I think that a lot of the money still stays at the national level, although the function is county level and we are running the hospitals. So that has to, again, be looked at so that we don't have the burden, but we don't have the money. And I like NHIF. We need to reform it so that even places like Makueni, who have some UHC version, also are able to fund the entire system through NHIF, but NHIF has really to be seriously reformed, and I think Makueni offers like a basic universal health care system, universal health coverage system that we can use in all the counties and then build on NHIF and so on and so forth.
Thank you. Commitment. Yes.
That I would like to say here about the role of the people, and it was raised here, and I think we are likely to end the debate without talking about that. That health is a human right. That all of us here sit on this side waiting for the government to provide us services, and when we don't get the services, we sit back and say it's the act of God. I think it's time that we actually educate the public to be able to understand how their finances are used. When there is corruption, what they need to do. There has to be what is called social accountability. I don't remember anybody taking the Minister of Health to court, for example, for corruption. I don't remember anyone going to block the MES if they didn't think it was working, because it is a human right. But we sit and then we complain about it. So one of the things we must educate the public about is that there's nothing like free healthcare. It's all our taxes. It's not somebody apportioning money by favor. It is our taxes. Please let us understand the Constitution and demand health as a human right. Thank you, Kivutha Kibwana, for what you're doing and the partnerships that we are having at Primary Healthcare to build health from the bottom. Thank you.
Thank you very much. Dr. Bosiro, your commitment, please.
This kitchen called Kenya, it has the chef, it has the ingredients, it has the fire. It's upon us to commit that we want to build a healthcare system. We're not going to replicate another country. We cannot bring the UK system here. We have to look at what's inherently unique to us, work with that, and make something that works for us instead of trying to keep aping other people or bringing outsiders to come and tell us how to do it.
Thank you very much. Dr. Aman, I'm going to come to you for the really solid commitment that we can get from government in terms of addressing UHC. But we are at University of Nairobi, and I'm told no student has actually spoken. Guys, there you go. All right, go ahead. Your last quick question. Yes.
Ladies and gentlemen.
Go ahead. Please, go ahead, sir. And then I'm going to come to the panel.
Ladies and gentlemen, brothers and sisters, friends and enemies. Actually, it was a very bad thing that I've been raising my hand for almost an hour, and you are just assuming.
Now you have the mic, sir. Please go to the question.
Okay.
Yes.
I think, number one, I have a few things to put across. Not many, but a few. The first thing, I want to appreciate the university for giving us this venue.
Sorry, go ahead. The mic is on.
I'm saying I want to appreciate the university for offering us this venue for such a forum. Okay. And
allow me to cut you short. Sorry.
No.
Please go ahead. And
okay.
make a
I
conclusive
think
remark.
coming up with a forum like this to discuss about the universal health coverage and not considering the health situation of the students at the University of Nairobi is being hypocritical and not healthy at all.
Sorry, I'm
At
going to
the
leave it at
University of-
that.
No, I'm almost finishing. Here at the University of Nairobi, our sanitation, the student health is very bad. Very pathetic. Our ladies are suffering in those halls
Sorry,
of
sir, I'm going
residence.
to cut you short because we are addressing a national issue and it looks like you're only focusing
This is a
on the
national
University of Nairobi.
issue. This is
Sorry.
a national issue.
I get you. All right. Sorry, I'm going to cut you short. I'm going to cut you short. Sorry about that. Sorry about that. Let me pass on the mic to civil society, please. Sorry about that. Let's pass on the mic just really quickly. Sorry. Let's get a conclusive remark. Kindly address the issues that we've raised today. I'm sorry if you don't go off topic.
Okay,
Please.
thank you. Thank you very much. My name is James Kamau. I'm from the civil society, Kenya Treatment Access Movement, HIV/AIDS activist and health activist. Mine is a very simple question to all of you panelists over here. Yes, we are talking about universal health coverage, but there are two issues that have not been addressed today. And I like what it was alluded to by my friend from AMREF. So I'll address a second one. Can we address the universal health corruption issues? 5.2 billion missing from Ministry of Health. 1.7 billion returned from Gavi. We have a lot of corruption issues. And these are some of the things that will not help us reach universal health coverage. Can we address that?
Thank you very much. Appreciate it. Thank you so much. Ladies and gentlemen, you agree that we're going to come back and still continue with these discussions, but we really need to get a way forward. If you may allow, please, let me pass it on to Dr. Man to really give a conclusive remark, and that will be your key takeaways, and of course, a commitment from government, of course, addressing the issues that have been raised today.
Thank you. I want to say that universal health coverage or delivering health to our fellow Kenyans, affordable quality health care, is a business of each and every one of us. And I think it does not serve us taking adversarial positions against each other, because we are working for one common cause, and that is to provide service to that Kenyan who may not be able to afford it right now. Let us not dwell in what has happened in the past. Let us look at what we have and how we can work with it the best way so that we can achieve that goal. Universal health care is all about health systems and strengthening health systems, be it leadership and governance, be it human resource for health, health commodities, infrastructure, service delivery. We have been talking about that for many years in the health sector. But this is an opportunity now to really focus on strengthening all those pillars of health systems. And I think it is a commitment that the Ministry of Health is undertaking to strengthen that. While at the same time, we cannot sustain universal health care without taking into consideration that we need to focus, maybe refocus, and re-engineer our approach towards primary health care to promote preventive and promotive medicine. And that's an area that the ministry is also now seriously focusing upon. The first interface of interaction between a patient seeking care and the health system occurs at the most basic level. We want to say that as a ministry, we want to move beyond that and into the community. And I agree with my colleague from AMREF that that is really a very, very important part of healthcare that we need to strengthen. We need to adopt a more proactive approach towards health delivery, not a receptive approach of waiting for people to present themselves at health centers, but really to go out there, to screen them, to do promotive medicine, to address issues of lifestyle so that we can be able to prevent the non-communicable diseases. Because we have always to keep in mind that universal health coverage means that you have a pool of resources that is spreading the risk so that everybody can benefit.
Thank you.
And if you are not able to prevent those diseases, you will at some point exhaust those resources. So I think that is the direction as a ministry we are taking, and I'm very grateful to be a participant in this forum because it's good to have forums like this receive opinions, constructive opinions that we can build on.
Thank you very much. Thank you very much, Dr. Mann. Thank you to an amazing panelist. Shall we all please appreciate our panelists tonight? And to you yourselves, guys, thank you so much for being an amazing audience. I know, yes, we have to come back. This has been the National Leadership Forum. A lot of critical issues brought forth. Please make sure that we can actually get your copy of the Daily Nation tomorrow, because we'll get some of these commitments also highlighted and get the way forward that you can actually address them next time that you're back right here at the University of Nairobi. I've been your host, Laban Clay Fonsero. There's been an amazing team working behind the scenes to make this happen. I want to thank you so much for you also for tuning in. Stay tuned to NTV right after this break, also for the news. All right, and enjoy yourselves. Goodbye.